Hi, my name is Steve Best, Technical Advisor for Nuco Training Ltd. Well, the much awaited, the much talked about and the much rumoured changes were announced formally on Monday the 18th of October 2010. I guess the odds-on favourite change was the possibility of introducing compression-only CPR, but this did not transpire. The surprising thing is that at first glance there are few major changes to the resuscitation protocol, but upon detailed investigation there are many subtle changes, and in particular the emphasis that must be placed in our teaching within certain areas of the resuscitation procedure. A lot of what I'm going to explain is already being taught in adult basic life support, but it's the emphasis when you are teaching it that's important. Much of what I'm going to say are extracts from the new guidelines, and the format I'm going to follow is that of the primary survey. Firstly, the Resuscitation Council say that a simple education-based approach is recommended when teaching CPR. Ideally, full CPR skills should be taught to all citizens. Initial or limited time training should always include chest compressions. Subsequent training should include ventilations as well as chest compressions. Those who have a duty of care, including first aiders and emergency first aiders, lifeguards and childminders, must be taught chest compressions and ventilations. Although the new basic life support algorithm does not mention about checking for dangers, the written sequence clearly states that you have to make sure the casualty, any bystander and you are safe. Therefore, Nuco Training will continue to use the acronym Dr. ABC in our teaching of primary survey. Here is a reminder of that acronym. D stands for danger. Ensure that the area is safe before you start your treatment for you, your casualty and any bystander. R stands for response. In respect of checking for a response, then gently shake the shoulders and ask loudly, "Are you alright?" Nuco will continue to use the acronym AVPU. Currently the P stands for pain or stimuli. In the new year, the P will read, "Place your hands on their shoulders and gently shake them." You must shout for help in all incidents. When obtaining help in dealing with a casualty who is not breathing normally, or if you suspect they may go into an arrest, then ask for an automated external defibrillator or AED if one is available. Only leave the casualty when no other option exists for getting help. A stands for airway. To open the casualty's airway, place your hand on their forehead and gently tilt their head back. With your fingertips under the point of the casualty's chin, lift the chin to open the airway. If you're on your own, use your mobile phone to call for an ambulance. B stands for breathing. You must check for normal breathing. In the Guidelines 2010, the absence of normal breathing continues to be the main sign of cardiac arrest in a non-responsive casualty. Your breathing check must not take longer than 10 seconds. If you have any doubt whether breathing is normal, act as if it is not normal. Agonal gasps are present in up to 40% of cardiac arrest victims. Therefore, first aiders and emergency first aiders should be taught to begin CPR if the casualty is unconscious or unresponsive and not breathing normally. It should be emphasised during training that agonal gasps occur commonly in the first few minutes after sudden cardiac arrest. They are an indication for starting CPR immediately and should not be confused with normal breathing. C stands for CPR for a casualty who is not breathing normally. When teaching CPR to lay people, and this group includes first aiders and emergency first aiders, then you must teach with an emphasis on chest compressions, but include giving breaths as the standard, particularly those with a duty of care. Rescuers should take appropriate safety precautions where feasible, especially if the casualty is known to have a serious infection such as tuberculosis or TB, or severe acute respiratory distress syndrome, SARS. During an outbreak of a highly infectious condition such as SARS, then protective precautions for the rescuer are essential, and this would include gloves and a face shield or mask. When giving chest compressions, the heel of one hand must be placed in the centre of the casualty's chest, which is the lower half of their sternum or breastbone. Use of the internipple line as a landmark for hand placement is not acceptable. In most cases, it will be possible to identify the correct hand position for chest compressions without removing the casualty's clothing. If you are in any doubt, you can remove outer clothing. Attention must be paid to compressing the chest to a depth of 5 to 6 centimetres and at a rate of at least 100 but no more than 120 compressions per minute. Allow the chest to recoil completely after each compression. Deliver each rescue breath in 1 second rather than 2 seconds. Giving 2 breaths, including yourself taking in a breath in between each one you give, should not take longer than 5 seconds. Then return to the casualty's chest without delay. Repeat the cycle of 30 compressions to 2 breaths. Where the rescuer is unable or unwilling to give rescue breaths, then the emphasis must be to continue with chest compression only CPR. If there is more than one rescuer present, then another should take over CPR about every 1 to 2 minutes to prevent fatigue. Ensure the minimum of delay during the changeover of rescuers and do not interrupt chest compressions. Regurgitation of stomach contents is common during CPR, particularly victims of drowning. If regurgitation occurs, turn the casualty away from you. Keep them on their side and prevent them from toppling onto their front. Ensure their head is turned towards the floor and their mouth is open at the lowest point, thus allowing vomit to drain away. Clear any residual debris from their mouth with your fingers and immediately turn them onto their back. Re-establish the airway and continue rescue breathing and chest compressions at the recommended rate. There is no evidence that oxygen administration is of benefit during basic life support in the majority of cases of cardiac arrest before healthcare professionals are available with equipment to secure the airway. Its use may lead to interruption in chest compressions and is not recommended, except in cases of drowning. So let's have a quick recap. Check for dangers. Make sure the area is safe. Check for a response by gently shaking their shoulders and asking them loudly, "Are you all right?" Shout for help if you have no one with you. Tilt the head back, lift the chin and open the airway. Check for normal breathing. Take no longer than 10 seconds to do this. If your casualty is not breathing normally, then ask your bystander to call for an ambulance. If you're on your own, then you must make this call yourself. Start CPR with 30 chest compressions at a depth of 5 to 6 centimetres and at a rate of 100 to 120 compressions per minute. Open the airway and give 2 breaths. Take no longer than 5 seconds to complete the breaths. If you are unable or unwilling to give them, then continue with compression only CPR. Repeat the cycle of 30 compressions to 2 breaths. Once CPR has started, the rescuer, first aider, emergency first aider in our instance, should only stop CPR when the casualty shows signs of regaining consciousness, such as coughing, opening their eyes, speaking or moving purposefully, and starts to breathe normally again. The only other occurrence that you should stop is if qualified help takes over or you become exhausted. Let's go back to our primary survey slide. If your casualty is unresponsive, then the C stands for circulation. Treat any major bleed and treat other conditions such as burns and breaks. It is imperative to maintain an open airway, so place your casualty in the recovery position and monitor their breathing until qualified help takes over. Where the casualty is unresponsive but breathing normally, then the casualty must be continually assessed whilst in the recovery position. CPR must commence immediately if their breathing is not normal. If the casualty has to be kept in the recovery position for more than 30 minutes, turn them to the opposite side to relieve the pressure on the lower arm. In respect of the chain of survival, there has been one fundamental change which lies within the first link. The first link of this chain must now indicate the importance of recognising those at risk of cardiac arrest and calling for help in the hope that early treatment can prevent arrest, rather than waiting for the casualty to go into cardiac arrest. There are no changes to the choking procedure. As a reminder, if your casualty becomes unconscious, then call for an ambulance immediately and start CPR by giving 30 chest compressions followed by 2 breaths, and repeat this sequence of 30 to 2. You must apply the same CPR rules as discussed earlier. If the initial rescue breaths of each sequence does not make the chest rise as in normal breathing, then before your next attempt, check the casualty's mouth and remove any visible obstruction. Recheck that there is adequate head tilt and chin lift. Do not attempt more than 2 breaths each time before returning to chest compressions. As far as defibrillation is concerned, there are no changes to the algorithm. Again, apply the same rules as discussed previously in respect of primary survey and CPR techniques. Well, there you have it. The changes to adult basic life support now place more of an emphasis on effective chest compressions, push harder and faster, take less time to administer breaths. Changes have been announced in respect of paediatric first aid, particularly CPR. There will be a separate bulletin relating to this. As you can no doubt appreciate, these changes affect many resources including books, PowerPoint presentations, assessment papers and training notes. Nuco Training is on the case and they anticipate that these changes will be introduced in January 2011. Until this time, please continue to teach your current practices. Nuco will formally announce a start date later in the year. For the students that you have already trained, then they will be fine. There is no requirement to update them on the changes until they come back on a requalification course at some point in the future beyond January 2011. If you require an in-depth copy of the changes, then visit the Resuscitation Council UK website, www.resus.org.uk. Should you need any further clarification, please do not hesitate to contact Nuco Training direct on 08456 444 999 or contact them by email at inquiries@nucotraining.com. I hope you found this presentation informative and I appreciate you watching it. Please look out for further bulletins on Nuco Training TV in the future. Thank you.